Welcome, everyone. Thank you for taking the time to attend our webinar today. We know your time is really valuable, and so we've got a wonderful program packed, hopefully, to answer your questions about cognitive integration. I'm Dr. Leslie Fall. I'm the CEO of Aquifer. In this session today, my colleagues and I invite you to engage with us around the challenge of fostering cognitive integration of basic and clinical sciences in the minds of our learners. Clearly, this is a really timely and important topic as we have record-breaking attendance today. And so I'm taking a little bit of time to make sure that everybody has a chance to log in and sign in and get themselves all settled. But you might want to put your seatbelts on because we have a lot of wonderful information to share with you today. As part of our time together, we really hope to provide you with some practical lessons that we have learned through developing and using novel curricular approaches to achieve this aim through Aquifer and at the institutions from our presenters today. I'd like to take a moment to briefly introduce my esteemed colleagues. Amy Wilson-Delfosse is a Senior Director of Aquifer Sciences and the Associate Dean for Curriculum and Professor in the Department of Pharmacology at Case Western Reserve University School of Medicine. Khiet Ngo is a clinical lead in our Aquifer Sciences initiative. He's an assistant professor of basic and clinical sciences and assistant dean for curricular innovation at Loma Linda University School of Medicine. Esther Dasari Dale is the director of psychometric assessment for years 1 and 2 at the University of Minnesota Medical School. Before we begin, a few housekeeping notes as usual. Our session today is being recorded, and we will be providing you with a link to the recording afterwards, along with a brief feedback survey, and we really appreciate your thoughts afterwards. While you've been automatically muted at this time, we have a number of interactive activities to enable you to provide your own input, as well as a moderated question and answer session at the conclusion. Throughout this webinar, the Aquifer staff is available to answer your questions in the chat feature as well. For those of you who are new to Aquifer, we are a nonprofit health professions organization founded in 2006 with the mission to deliver the best in healthcare education through collaborative development and research of innovative, high-impact virtual teaching and learning methods. Our model is built on extensive collaboration with other national health professions organizations, such as Aquifer's collaboration with the International Association of Medical Science Educators, or IAMSE, to develop many of the approaches and tools we will present today. All of the Aquifer content is authored, peer-reviewed, and continuously maintained by a small army of volunteer faculty educators and a growing cadre of students recruited through these organizations and our subscribing institutions. Of note, Drs. Wilson-Delfosse, Ngo, and I receive some financial support from Aquifer for our work that we are going to present today. Now that I've told you a bit about us, we'd love to learn a little bit more about you. Megan, would you please launch the first poll? Okay, let's see who's here today. So 21% of you are basic scientists. That's wonderful. 14% of you are clinicians. We currently have no student or residents, but we hear there's a few of them signed up for the webinar today. 55% of you consider yourselves as educators or administrators, and 10% of you describe yourselves as other, and hopefully we'll learn a little bit more about you as we go through today. As you can see, we have a full program for you, and we're confident, no matter your role, that you'll come away with at least one idea to address the integration challenge that you face. My own journey into this work began over 20 years ago as both a pediatric hospitalist and a clerkship and residency program director, working side by side with medical students and residents. During rounds, I was becoming increasingly frustrated by my trainees' inability to leverage and use the basic sciences they had clearly mastered in the pre-clerkship curriculum when making a routine patient care decision about diagnosis, workup, and management, particularly in my mission to reduce unnecessary blood draws and use of expensive and often empiric therapies for my pediatric patients, many of whom were economically disadvantaged. Why were these bright and motivated learners struggling so much? It was here that my passion to solve this challenge was born. Now let's turn a bit more to learning about you and where you are in your own journey. All right, Megan, here we go. Will you please launch the second poll? Wonderful. Thank you, everybody. So it looks like only 5% of you haven't started yet. About 19% of you are in an early exploration phase. 43% of you are beginning to integrate, and 43% of you, 43% of you are beginning to integrate, and 33% of you have meaningfully integrated something in your curriculum. Congratulations, because as we all know, this is really hard work. So I'm going to turn the program over now to my colleague, Amy Wilson-Delfosse, to explore with you a bit more the barriers to integration and then to tell you about one of our solutions. Amy?
Thanks, Leslie. Well, that last poll certainly demonstrated that there's a lot of interest and activity within the curricular space of meaningfully integrating basic science and clinical education. Would you now please share with us, using the chat feature in Zoom, what barriers to integration you all have encountered at your own institution? So just go ahead and type into the chat window for me, please. Oh, how wonderful. No barriers. Time. Yeah, time is really difficult, isn't it? Budgeting. Oh, lack of buy-in from the students. This is fabulous. All these comments, I can hardly keep up with them. Not enough clinician input. Buy-in from other faculty, developing meaningful collaborations, time and commitment of peers. Basic scientists don't know the clinical medicine, and clinicians don't know the basic science. So many of these concepts, of these comments are really around that relationship that you need to build between basic scientists and clinicians, and the need for that kind of communication. Again, time, faculty willingness, time comes up over and over again. Varying strengths among virtual colleagues, of course, challenges surrounding COVID. Oh, the clinicians, right? They're so busy with clinical care, and how do you protect their FTE to do this? Just really, boy, you are hitting, I think, on all of the challenges that we have noted as we've been working on this curriculum. So thank you so much for sharing your thoughts. We do welcome you to continue sharing your thoughts in the chat feature. And now I want to tell you about the work that Leslie and I have been doing with dozens and dozens of nationally recognized basic science and clinical educators. We've spent the last 8 years developing what we call the Aquifer Sciences initiative. And all of our efforts have been focused on the conceptualization and development of tools and opportunities for learners. Learners, that would be students, but also we as faculty are learners, to engage and integrate basic science concepts to support and justify clinical decisions. I want to share with you now the story of how Aquifer Sciences was born. The story begins in 2012 when I was the president of the International Association of Medical Science Educators, also known by its abbreviation as IAMSE. This is a health professions education association in which I know that at least some of you have membership. Welcome today. IAMSE was founded in 1988 by a small group of basic science medical educators and has subsequently diversified its membership to include basic science and clinical educators from all disciplines and all health professions from around the world. I met the CEO of Aquifer, my co-presenter today, Dr. Leslie Fall, at a IAMSE meeting. Leslie came by the IAMSE booth and was very clear in her belief that basic science is important in the context of clinical learning. And she was interested to better discover how basic science could meaningfully integrate into virtual clinical learning resources. Now, I have to admit that I was actually stunned that a clinician was approaching a group largely known for its basic science prowess, telling us how important basic science is for clinical practice. After all, aren't we basic scientists usually the ones who are always trying to justify to students why they need to study and remember their basic sciences? So after somewhat shocking me with her genuine interest in basic science, Leslie then stumped me with a question. She asked, "Where can I find the National Basic Science curriculum?" Yeah, I was a bit perplexed by this question, never having actually considered that basic science educators from all of our basic science disciplines would ever have gotten together to agree on a single basic science curriculum. Now, I knew that some disciplines had put forward curricula for their own areas, but certainly there was nothing I could point to as a single overall basic science curriculum that was validated as being clinically relevant or justified. The National Board of Medical Examiners does have a step 1 content outline, but that didn't feel very satisfying as an agreed upon curriculum or necessarily something that's validated as being clinically relevant. Not at this first meeting, but over time, Leslie reminded us that we were the International Association of Medical Science Educators and that we should be the ones to determine a national curriculum. I found that statement a bit difficult to argue with. After all, she was right. IAMSE is an organization and a membership uniquely positioned to develop just such a curriculum. So we established a formal working relationship between Aquifer and IAMSE and proceeded to recruit teams of basic scientists from IAMSE representing all of the major basic science discipline, and teams of clinical educators from the National Aquifer Faculty Consortium representing all the major clerkship clinical disciplines. The first task that we gave our basic science discipline teams was to articulate the top 10 core learning objectives in each discipline that every medical student should understand in order to support safe, effective, high-quality clinical decisions during their clerkships. Our teams spent about 3 months collaborating within teams and across disciplines, narrowing and refining their lists of core learning objectives. When we compiled all the lists of these top 10 objectives from each basic science discipline and shared them with our clinician educators to review and assure relevance, we discovered we had a language problem. The clinicians said, "Where's the basic science? Where are the cells and molecules?" At this point, the basic scientists got a bit frustrated, quite honestly, because they had written objectives about basic science concepts. Why couldn't the clinicians see that? The cells and molecules were right there. This was our first realization that clinicians and basic scientists package this basic science information differently, and we needed to establish a new way to communicate. In addition to creating content, we needed to establish a means by which basic science and clinical educators could communicate and work together toward an understood shared goal. Leslie's going to talk a lot more about all of this a bit later during the webinar. For now, though, let me share with you our first major breakthrough. Concepts. Concepts are the common language that both basic scientists and clinicians can agree upon, understand, and apply. So we apologize to our teams for giving them the wrong directions when we asked them to write objectives. And yeah, for wasting about 3 months of their time, and then asked them to write the top 10 core clinically relevant concepts within each basic science discipline that every medical student must understand in order to support safe, effective, high-quality clinical decisions. And thus was born the foundations of the Aquifer Sciences curriculum, the top 10 basic science concepts that a clerkship medical student needs to understand in order to support their clinical decision-making. Each of these concepts has been painstakingly vetted and approved by clinical educators from each of the major clinical clerkship disciplines as being regularly relevant to a student on their clerkship. Once we got the concepts right, our basic science and clinical educators were able to collaborate to develop integrated learning objectives, each of which asks students to justify clinical decisions and avoid harm by engaging their understanding of basic science. Leslie's now going to explain the conceptual framework that underlies the work our teams have been doing, and will introduce you to the tools that support cognitive integration of basic science and clinical medicine. Leslie?
Thank you, Amy. So I'll continue the story now, sharing my own story and providing you with some additional background about what led me to approach that table at IAMSE. While on call one evening, a medical student called to present to me a new admission of a 5-day-old infant admitted for neonatal hyperbilirubinemia, better known as newborn jaundice, which was presumed to be due to insufficient breastfeeding based on the brief admitting history, physical exam, and labs. The infant was a bit sleepy and breastfeeding was only going okay. The elevated bilirubin was all indirect, which was to be expected, and there was no ABO or maternal fetal immune setup. I concurred with the presumed diagnosis that night and standard management plan. The next morning, however, the infant's elevated bilirubin had not really improved much despite the phototherapy and now clear evidence of good breastfeeding. The resident and student assessment on rounds assumed that the infant just needed more phototherapy, but by now the clinical findings no longer supported the provisional diagnosis to me. I requested that a complete blood count and smear be sent, which showed that the infant was becoming alarmingly anemic due to clear evidence of non-immune hemolysis. Our pathologist confirmed that the infant's smear was consistent with hereditary spherocytosis. Now, this was a smart and strong team that had proven themselves to me over the past few weeks. And of course, they were really upset that they had not considered this possibility in their workup. So why did this happen? Prior to starting our work, 2 very strong models of curricular integration had already been disseminated and were in widespread use. Published in 2000, Ron Hardin's model described a ladder of integration to be climbed by curriculum deans and their faculty as they moved out of isolated curriculum planning and teaching up through the various stages of first harmonizing and then progressively integrating efforts between departments and their courses. In 2012, Ellen Goldman and Scott Schroth took a more granular and tactical approach, starting first with programmatic integration and then working backwards through course level and then session level integration decisions. While we found these frameworks really useful, they lack the focus that we wanted on learning level integration. Luckily for us, right around this time, Mahan Kulasegaram, Nikki Woods, and their colleagues at the Wilson Center in Toronto published their groundbreaking framework. In their 2013 paper, they asserted that meaningful integration is a cognitive activity and that it occurs first and foremost within the mind of the learner. They concluded by promoting the use of learner-centered, content-focused, session-level curricular strategies to achieve this objective. Through their work, we realized that curriculum efforts should serve as a cognitive compass rather than the end in itself. So let's take this back to the story that Amy gave and the example stories that I began at the beginning. So how do you drill down to create cognitively integrated curricula that is both deeply relevant to the clinical learner and their practice, while at the same time useful to an institutional program? That's a really hard problem. Additionally, though the early and intense collaborative efforts to create our curricular objectives, we discovered that an even deeper challenge existed, that of truly unpacking the expertise of basic science and clinical faculty in a manner that would enable them to work together efficiently and effectively. And many of you brought that up in the chat comments as well. So for example, as Amy just recently noted for you, during the development of our biochemistry objectives, I asked the basic science faculty team to write a learning objective focused on newborn bilirubin metabolism that was clinically relevant. And this is the objective they provided. Now, as a clerkship director and clinician, I admit it was certainly clinically relevant. But my comment was the first back to the team, to which Amy alluded, which was, where is the basic science in this objective? I mean, where are the cells and molecules? The basic science team members essentially answered me by saying, the bilirubin is right there. Don't you see it? And this is when we realized, as Amy mentioned, that we needed to take a big step back to define and use the core concepts as the accepted common language between the basic scientists and the clinicians to help speed the effective translation of the cells and molecules learning into the clinically relevant problems and decisions faced by the students in their clerkship years. So let me show you more pragmatically what that looks like for this clinical problem in our Aquifer Sciences curriculum. The problem begins with the basic science core concept of waste and toxin disposal, routinely covered in the biochemistry curriculum. The understanding of waste and toxin disposal is critical in both pediatrics and family medicine in caring for infants with the common condition of newborn jaundice. In caring for infants with newborn jaundice, a clinician learner is expected to apply this understanding when making numerous decisions regarding the diagnosis underlying the jaundice, further workup, management, expected course of illness, and prevention of further illness. You'll note that all of the learning objectives in the curriculum are now written around direct clinical application through one of these 5 core decisions that must be routinely made by clinicians in practice. In this example, understanding the concept is foundational to making a diagnostic decision when interpreting laboratory results commonly obtained in working up a newborn presenting with jaundice. In addition to understanding the core concept, however, the learner must also possess the underlying basic science knowledge relevant to the patient problem in order to apply that concept and the knowledge to solving the problem and making a decision. And so for each learning objective, we have provided a brief teaching point demonstrating application of the core concept to the specific patient problem and decision outlined in the objective. Finally, we wanted to ensure that the clinical importance of this understanding was clearly articulated and driven home. Written by the clinician team members, these harm statements describe the potential adverse outcomes, either physiologically to the patient and or economically to the patient and or to the health system as a whole, that occur when a clinician fails to understand and apply the foundational basic sciences behind the decision. My original aim was beginning to be realized. Our core concepts, core conditions, integrated learning objectives, and more can be freely accessed through our curriculum database website. The curriculum is actively maintained by an editorial board of IAMSE members. If any of the authors or editors are in attendance today, we deeply thank you for your efforts. Since publishing the curriculum over 3 years ago, we've had a great deal of outreach from many programs telling us how useful the core concepts and clinical rationales have been to their curriculum redesign efforts, particularly to ensuring the pre-clerkship curriculum is both comprehensive and yet clinically focused. I'm now going to turn the program over to Dr. Esther Dasari Dale to tell you about her innovative use of curriculum as a framework for the development and mapping of assessment questions at the University of Minnesota. Esther?
Thank you, Leslie. As all of you who have taught preclinical students know, they demand high quality multiple choice items, both for formative and summative assessment. Our answer and our design logic to these students leveraged a decade of research from the Aquifer Science Initiative. How did we do this? We took a fresh look at the content areas and assessment domains of preclinical education. We started by creating a table of specifications inspired by Bloom's taxonomy so that 3 frameworks, the USMLE content list, the course objectives at our own institution, and the domains of knowledge of the Aquifer Science Initiative could directly inform a bank of 10,000 items. These frameworks, plus the employment of 35 student writers, resulted in a unique item bank. We rethought assessment in terms of 3 curricular challenges. And I'll just respond to each of these challenges. First, everyone is looking for cohesion. Cohesion exists in the mind of faculty, but it may be unrecognized by students. Faculty have an implicit framework of the links between their lecture content and the test items. In some contexts, the relationship is explicitly taught, but in others, the students themselves are expected to deduce that framework. Second, students also need to own their own learning. So the topic of co-production with medical students has been discussed in the context of curriculum, but it has rarely been applied to assessment. Medical education researchers discussing co-production have said the following: like the relationship between patients and providers, the relationship between learners and the teacher requires the integrated experience of each, nested in the context of their system, community, and society to optimize incomes. We found that MS4 students can play a key role as an intermediary between faculty experts and MS1 or MS2 students who are relatively novices. A third curriculum challenge is a double-edged desire. As you know, students desire more and more questions integrating basic science and clinical content. Basic science faculty also have a wealth of knowledge, so they desire help in sampling the right basic concept. Faculty also aim to test the appropriate content at the correct cognitive level, but do not always know how and may require some guidance. To address challenge 1, in our project, student writers were given some flexibility to choose the discipline of their items. So they could draw from the Aquifer core concepts, but we did require them to complete a detailed item template on Qualtrics that required them to nest each and every question in one of the frameworks using an efficient tagging system. Most of all, we pushed Aquifer because it was so easy for students to tag to the core concepts. To address challenge 2, item writers, mostly MS4 students, were hired to write clinically based questions that incorporated the most high yield basic science knowledge. And these students wrote, tagged, and reviewed items. We provided 6+ hours of professional development on item writing and continuous feedback to these writers. Finally, after the items were written, we put them through faculty review. The younger students would learn from the MS4 students, and the MS4 students would have a chance to give back. Next slide, please, Leslie. All right. The next steps include continuous faculty review of items, field testing, and generating psychometric data of completed items. Even existing but suboptimal items can be rewritten using item writing guidelines and tagging them to the Aquifer disciplinary core concepts, disciplines, systems, and learning objectives. Early wins include the following. While our grant timeline had us creating a bank of 10,000 items in 3 years, with the help of the Aquifer curriculum database, within 4 months, we generated 3,200 items, or 1/3 of the bank goal. A second win we did was this. We added the tag of DEI to our template, and our hope is to look for DEI objectives and blend that with all of the work that is done in Aquifer. Finally, Standard item writing training was developed. We wrote almost a white paper, and we used that as a guide to train all of our item writers. So we ended up with very, very consistent items. So Leslie?
Thank you, Esther. That is an impressive project. We were so thrilled to see that the work that we had done previously was really able to help you in the work that you and your team had done. As proud as we are of the curriculum and its utility for many programs, our ultimate aim, however, has always been to create learner-centered, content-focused resources that directly promote cognitive integration in the classroom and in practice. We'll spend the rest of our hour now describing one of our own pedagogical approaches, the use of integrated illness scripts and their associated mechanism of disease maps to foster tangible cognitive integration within the minds of learners and among faculty. To finish this example, a number of integrated illness scripts could be developed for core clerkship conditions that present as hyperbilirubinemia and newborn jaundice, such as breastfeeding jaundice and ABO incompatibility. Let's talk more now about how to do that. For those of you who are unfamiliar with integrated illness scripts and illness scripts in general, I'll provide a brief introduction here to set the stage for our use cases. If you're interested in learning more, we have a number of resources to get you started and a great deal of additional information on our website, which I'll highlight for you at the end. An illness script is the term for the mental model by which a clinician stores and recalls relevant biomedical concepts and their relationships to clinical problems, such as diseases, conditions, or syndromes. Expert clinicians draw from a repertoire of scripts developed and honed through years of expertise to drive purposeful clinical data gathering, compare and contrast diagnostic hypotheses, and direct initial management decisions. Novice clinicians naturally begin the process of illness script development the moment they begin learning about diseases and conditions. Targeting these earliest learning experiences and then building upon them is the primary aim of our Aquifer Sciences initiative and its pedagogy. In the traditional model of an illness script, knowledge of each clinical condition is organized within a clinician's memory into three main components: the enabling condition, or predisposing epidemiologic and structural factors that influence a patient's probability of the disease; the fault, the initial trigger or underlying pathophysiologic insult brought about by the enabling conditions; and the clinical consequences, the patient's chief concern, signs, and symptoms to which the fault gives rise. Importantly, research demonstrates that how a clinician encapsulates relevant information within these components facilitates or hinders accurate and efficient information retrieval during clinical decision-making. As an example, here's an illness script for asthma, organized in the traditional format. On the surface, this appears both succinct and nicely integrated, providing novice learners with a cogent cognitive framework for learning and applying both the basic sciences relevant to asthma gained in the pre-clerkship curriculum on the right, and then adding and integrating the more clinically relevant information gained during their clerkship education on the left. Initially, this is exactly what our team planned to create, and the clinicians were pleased with the approach. The basic scientists on our team, however, felt strongly that we were missing something because the basic science still felt too segregated and off to the side. Luckily for us, once again, our colleagues at the Wilson Center had recently published a paper in the dental education literature that answered the concern and suggested a much better approach. In this published study, published around the same time as the cognitive integration paper, they asked dental students to learn about 4 dental conditions diagnosed by X-ray that are easily confused. Half of the students learned the conditions using the standard framework called segregated in this study, and the other half were taught a more integrated approach. In the segregated approach group, a concise paragraph teaching the basic science mechanism for each condition was provided, followed immediately by a paragraph outlining the diagnostic clinical radiographic features of the condition, much like the traditional illness script structure I just showed you for asthma. When given unknown radiographs, students in the segregated approach group correctly diagnosed the condition 70% of the time immediately following the training, and then dropped to about 68% accuracy 1 week later upon retest with new conditions. In the integrated approach group, each condition was taught with the same basic science content, underlined here in blue, integrated with the same clinical radiographic feature content, underlined here in orange, but in a deeply integrated sentence-by-sentence fashion. As you can see in the results, the worst performer in the integrated approach group in the delayed testing still outperformed even the best performer in the segregated approach group during the immediate testing. Thus, our idea for developing integrated illness scripts was born. Continuing with the asthma example, an integrated illness script begins with a definition of the illness, followed by a description of the underlying pathophysiologic insult or trigger, and the epidemiology of the enabling conditions. This overview is then followed by a list of the most common clinical features of the condition, each with its own detailed description of the basic science causal explanation for why this feature occurs in this condition. For example, the basic science explanation for why dyspnea occurs specifically in patients with asthma. As an added component, our integrated illness script approach also includes the basic science core concepts derived from our curriculum that underlie each described causal mechanism. In this manner, the integrated illness script provides support for inductive clinical reasoning from the observed features back through the relevant causal mechanisms and basic science concepts to the originating insult, much the way a diagnostic clinician must think. The accompanying mechanism of disease, or MOD map, is a unique type of linear concept map that provides an integrated basic science visual representation of the illness. Starting with the original insult, the MOD flows in a deductive causal manner, consistent with the way a basic scientist would explain the occurrence of a given clinical feature or set of features in a known disease. Taken together, the integrated illness script and the mechanism of disease map provide a holistic, cognitively integrated, and clinically relevant overview of asthma that may then be used broadly in clinical decision-making and teaching. Let's turn our attention now to how the pedagogy of the integrated illness script and mechanism of disease map can help with the challenges that we've all experienced with implementing the principles of cognitive integration in our own institutions. We fully realize that meaningfully integrating the learning of basic science and clinical medicine in the classroom or in clinical settings can certainly feel like Sisyphus rolling the boulder up the hill, but in this final section, we're here to tell you it can be done. Over the next 10 minutes, Amy, Khiet, and I will share with you a bit about our own experiences across the undergraduate medical school curriculum. I'll start by telling you about my selective with second-year medical students at Dartmouth. The challenge is a common one, that of helping pre-clerkship students to integrate and clinically apply what they have learned about a single common condition across a variety of basic science courses in a given semester. To establish the curriculum, I collaborated with the preclinical dean to identify 6 common conditions that are being taught in the cardiorespiratory block and associated PBL sessions. I then developed a short patient vignette for which these 6 conditions would reasonably be either the leading diagnosis or on the differential diagnosis. Working in teams with one student lead, the students developed an integrated illness script and MOD map for their given condition across 6 evening sessions during the semester under my direction and feeding the pizza. In the final session, the students, collaborating with all of the material as a common mind, applied the scripts and maps by comparing and contrasting them to defend a leading diagnosis and a prioritized differential diagnosis for the patient in the vignette. Luckily for them, they got it right and they got dessert. Despite the added evening sessions to the students' already packed schedules, they appreciated the session and found the experience valuable in their compulsory learning activities, including seeing patients, studying, and exam performance. I'll turn it over now to Amy to tell you about her use of these tools in the third-year curriculum. Amy?
Thank you, Leslie. So let me very briefly and at a high level explain to you what we do and how we use the integration tools Leslie described at Case Western. Our clerkship students gather in small groups of about 6 to 9 students from mixed clerkships and are facilitated by a clinician educator on Friday afternoons. This is truly an undifferentiated patient curriculum with students meeting the patient in that afternoon's case in the exam rooms of our simulation center. The details of the case are discovered by doing a history and a focused physical exam on the standardized patient, and then working through a differential diagnosis as a team. Once the small group team has established the top 2 or 3 conditions on their differential, then they work collaboratively to create the integrated illness scripts and mechanism of disease maps for those diagnoses. By comparing the mechanism of disease maps, the students are generally able to justify their top diagnosis and begin to consider good choices about options for further workup and treatment. We have also developed an approach to integrate the patient's context of their illness into the mechanism of disease map, and so are, in effect, integrating the 3 pillars of medical education: basic, clinical, and health system sciences. Now, while it can be a challenge sometimes for students to appreciate in real time the value of curriculum, it's nice to see that our learners move on in their clinical training and value integration of basic science and clinical education. This emerges as they move toward clinical mastery and independence. And what you see here is an example quote from one of our 4th year students who commented that participating in this kind of integrated course forced him to really justify why each condition he was testing for made sense and why it deserved to be tested for. That's the kind of thinking we need our future clinicians to employ to avoid harm and provide high-value care. And another really positive outcome for us is that faculty have a great time teaching in this kind of integrated program that allows them to engage their clinical expertise and consider right alongside of the students how basic science can improve clinical decisions. After the first year, we actually had to increase our number of small groups by 10% in order to accommodate all the clinician educators who wanted to facilitate. That is, I think, almost unheard of. I'm now going to turn the discussion over to Khiet to tell you more about what he's doing with 4th year medical students at Loma Linda School of Medicine. Khiet?
Khiet, we may need you to unmute yourself.
Okay, sorry.
Great,
all right.
Thank you.
Yeah, thank you. So thank you, Amy. So Leslie has already very nicely articulated the challenges of cognitive integration. So one of the goals in our new discovery curriculum at Loma Linda is that we not only wanted students to be able to be consumers of knowledge, but also to build skills of deconstructing, analyzing, and reconstructing their own conceptual understanding. So the challenge, of course, is how do we do this strategically? So after learning about Aquifer's integrated illness script and mechanism of disease maps a few years ago, it became clear to us that these were truly boundary crossing tools that can be used for teaching, learning, as well as clinical practice in both the preclinical as well as clinical settings. So thus our strategy at our campus was to have students use these tools to build their own cognitive integration framework throughout the 4 years of medical school. So we actually ended up starting backwards in the sense that we first introduced the scripts and maps to our senior students as part of a senior basic sciences elective. But then beginning with our new discovery curriculum just this year, all of our first year students developed scripts as well as maps as part of our problem-based learning curriculum, which we run throughout the first 2 years. Now, most recently, similar to the SAMI strategy that Amy just described, we're connecting our PBL curriculum actually with our clinical skills curriculum as well as our simulation labs experiences. Now, on the next slide, I just wanted to share with you sort of the product of some of the things that our students have done. On the left is a modified integrated illness scripts for bacterial endocarditis that we just finished on our block. And then on the right is a mechanism of disease map that one of our student teams created on Cushing syndrome. So it's just really been really rewarding to see sort of some of the actual product of of cognitive integration on a visual basis. And then on the next slide, I'll just sort of wrap up by sharing with you some of our few early wins. So we do think that this has really given students an opportunity to repetitively practice building and applying their own cognitive integration framework. And having students build these scripts and maps, we're really making visual an important tool that was really once hidden in the minds of learners and faculty. From a faculty standpoint, it's been exceptionally rewarding to be able to actually see the progress that the students are making and really assess their progress and offer feedback on the process of cognitive integration. And then lastly, all of us are thinking about assessments. One of the strategies that we're using is to actually give our students essay exams to really see if they have connected a lot of the things that they've been working on with their integrated illness scripts and mechanism of condition maps. And certainly, I won't read both quotes here, but universally, from first years to fourth years, our students find that the activity of creating an integrated illness script and mechanism of disease map very challenging, because it's something that we typically, I think, don't do enough of in medical school. But they also admit that on a clinical level, it's been extremely useful for them. So with that, I'll hand it back to Leslie.
Great. Thank you very much, Khiet. Some incredible work that you've been doing at your school as well. So I know we have packed a lot into this hour. If you'd like to review the information in more detail, we have recently published a white paper outlining many of the principles we've covered today. In addition, we're very pleased to announce that we are beginning a series of interactive, hands-on, online virtual web shops for those of you who are interested in learning how to construct an illness script or an MOD map for use in your own curriculum. The dates of our first web shops are listed here, and more dates and sessions will be forthcoming over the summer. For those of you who are attending IAMSE, we'll also be doing both web shops as a pre-conference workshop at the June meeting as well. We encourage you to bookmark the Aquifer Sciences page on our website and to watch your inbox for continuously updated information about these activities. And additionally, if you haven't already, we really do encourage you to explore our Aquifer Sciences curriculum, which is available online. We have also been very busy behind the scenes preparing a beta release of a series of integrated illness scripts and MOD maps for core clerkship conditions, which in the future will also provide cognitive integration support to our signature courses and their cases. Many of these were originally authored through a very productive collaboration with 6 competitively selected pilot development schools, and thank you to any of you who are on the call as well. We're pleased to announce that for academic 2021-22, the beta series will be available to our curriculum partners, those schools and programs that subscribe to our full suite of signature courses. Beginning with an initial set of 20 scripts and related curriculum integration tools and guides, an additional 30 to 40 scripts will be released throughout the next academic year as they become available. And then we anticipate the full series will be available to all institutions by subscription in academic 22-23. I'll now open it up to everyone for your questions. Eileen? And you're on mute now, my dear.
Thank you. A lot of great information there. Wow. Thank you, everyone. I'm Eileen Oshesky. I'm the Director of Communications and Engagement here at Aquifer, and I am here to help bring forward your questions. So feel free to drop them into the Q&A panel, and I will bring them to our wonderful panel. So I've got one in the panel right now, and that's a question that's, is there any evidence that, say, after 10 years out, students trained with an integrated approach are better clinicians? Leslie, do you want to take that one?
I figured you were going to throw that one at me. So, it's a wonderful question, and that truly is the intent and the hope of the work that we're doing. So we've tried very hard to base all of the tools and the approaches that we're working on in the evidence supplied by our colleagues at the Wilson Center, and in many of you who have published about the integration between basic science and clinical medicine, with the intent that all of our work is around improving decision-making in students. Unfortunately, it takes a lot of time and energy and effort to develop these tools. And so we truly believe that by using this approach, we will in fact build better clinicians. We wouldn't be dedicating our lives to doing this, I think, if we didn't. But stay tuned, and or better yet, participate with us, because we really do intend to see if in fact that's true.
Perfect. Thanks. I've got another question, and Khiet, this might be a good one for you. It says, how do you integrate the integrated illness scripts in the M1 curriculum? I know you had talked about doing that as well as you had, Leslie.
Yeah, so what we do is that with our undifferentiated problems-based learning cases, teams of students will actually get together and research and develop the scripts along with the mechanism of disease maps. And then what we plan to do is that they'll accumulate creating all these maps over 2 years. And at the end of our second year curriculum, we'll actually bring all those maps together and do an integrated block where they actually will use all those scripts in order to, make clinical decisions.
That's great. And that kind of gets us to the next question, which was, with the integrated approach in the didactic phase, does it need reinforcement again in rotations in order to be effective? And in other words, do the rotation clinicians need to buy in as well?
So I'll start with that one. So the answer, is absolutely yes. I think that really is the story behind our harm statements, particularly. We recognized that if the clinicians in the clerkship years were not bought into the approach, then obviously the students once again would be learning the material in the preclinical curriculum and not really applying it into the clinical curriculum itself. And so in many ways, that's why I think Khiet's work is very important, demonstrating, and Amy's as well, how we can use this across the classroom curriculum. But the next stage of what we're working on is then integrating it truly into the bedside and clinical curriculum. And I will just say that was my intent from day one. And so I really believe the next stage of this is really helping our clinical colleagues, many of whom have been working with us to actually create the script. That's the whole point of having these dyads of teams working together to ensure that the scripts are in fact very clinically relevant, such that one could easily pick it up at the bedside with a patient, or a Friday didactic session, or even a Monday morning report or M&M session, and really easily use it to deconstruct the basic science behind the common clerkship conditions that students see in the third and the fourth year. And that's why our integrated illness scripts have actually been built around the common core clinical conditions, as well as the database, specifically for that reason.
Excellent. I've got a question here about assessing performance. Could you elaborate on how to assess the performance on both the integrated illness scripts and the mechanism of disease maps?
Amy, you want to start with that one? And then Esther, have you take it from there.
Yeah, so I think that is a terrific question. And I will tell you, it's something that that we are struggling with, trying to decide what really is the most valid way to assess the outcomes of this kind of learning. So we're actually thinking about developing some specialized OSCE stations as part of our end of clerkship year clinical skills exam. I can't really say more about it than that because we're very much in the developmental stages. But I think you're probably hitting on with this question. Something that the previous question reflected was around how do we know that this matters, and that first requires that we think about what it is we're trying to measure. And I think asking students to be able to justify clinical decisions using their basic science is the direction that we would probably try to go. But I like that potentially within the setting of an OSCE. Esther, do you want to? You're our assessment guru.
Not at all. I'm so glad you said OSCE because that was what triggered in my mind. We go through all of the motions of creating these beautiful OSCE stations. We spend, hundreds of thousands of dollars to give students that experience. But sometimes I have the feeling that we underutilize them because we don't assess students. Yet we don't have enough clinician time to observe 179 students going through 8 stations or 12 stations. So this, once again, this seems like an amazing, amazing resource, because while maybe you're only looking at communication skills for year 2 students or a little bit about history and physical, students want to know how they did. They want to know how well they did on their differential diagnosis. So once again, I'm even more excited about the illness scripts than I was about the curriculum database. So I think you are really doing the work that everybody needs. So thank you.
Thank you. I think it's time for one last question. And I think this is an important one. It's how do you avoid resistance from peers and get them involved in the process of integration? I think it's one of the things that came up as a barrier at the beginning when we went through all those. Anybody have any thoughts on that?
Well, I'll start off by saying, I think one of the most profoundly rewarding aspects of this work that we never anticipated is by having our colleagues work together, basic scientists working across the various basic science disciplines and clinicians working together with the basic scientists has actually been ridiculously fun. And I'm not joking. I mean, we get so much gratitude from our colleagues for their work. And frankly, I will say many of them have said to us, this has sort of saved me from burnout, particularly during the pandemic. So, I mean, that sounds really corny, but we've just heard this over and over and over again. This is really fun. Clinicians desperately want to kind of go back to their basic sciences, don't have a ton of time, but if you give them a way in which they can do that and then have it be clinically relevant and frankly, be able to use it quickly with their learners at the bedside and their patients. We've been starting to use this with patients as well. People just find this ridiculously fun. So I would say that's the way to overcome the resistance, is really truly bring people together to use their kind of big whole mind together to create these.
Terrific. Thank you so much. I think that's probably all the time we have for questions. I'm going to have to turn it back to Leslie. I apologize to those of you whose questions we didn't get to, but this is a really interesting conversation. So thank you.
Wonderful. So let me just go ahead and just in the last minute or so, number one, thank you, Eileen, for doing our Q&A, and everyone for your fantastic questions. And we will take them all under advisement and encourage you to rejoin us in other sessions coming up. I saw a few I'd love to answer. Would there have been time, especially the one about giving students the answers versus having them construct them. But thank you, Eileen, and thank you to my colleagues today for really providing us with, just such valuable and inspiring use cases, and hopefully really demonstrating to everybody here that in fact, this work is not only fun, it's doable. The students and the faculty all really enjoy doing it. And hopefully we've kind of begun to crack the nut of cognitive integration as well. If you'd like to learn more about how Aquifer's tools can help you with your curricular challenges, whether cognitive integration or clinical integration, please don't hesitate to contact us. Our relationship managers are incredibly knowledgeable about all of our resources and how they can be applied to the unique yet frankly common challenges that everybody faces at their own institution and in your own unique program type. And lastly, thank you to everyone who participated in our webinar today. Again, we realize your time is valuable and we're very honored to have you here with us at the end of a long day, I'm sure. Thank you once again for attending, and we really look forward to hearing from you again soon. Have a great evening.